A family notices over several months that their mother is not quite herself. She is forgetting conversations she had the day before. She is confused about what day it is. She becomes lost in the middle of a sentence in a way she never used to be. She seems slower, flatter, less present than the sharp and engaged woman they have known for 67 years. They bring her to her doctor, and the word that begins to be used in those appointments is dementia, and the family begins the process of grieving a future they had not expected to face yet, while adjusting their lives around a diagnosis that feels irreversible and progressive. And sometimes it is. Sometimes the cognitive changes are the early expression of a neurodegenerative process that will continue regardless of any intervention. But sometimes, and with a frequency that is not rare and not theoretical, the cognitive changes are not dementia. They are medication. They are the accumulated anticholinergic burden of 3 or 4 drugs that, individually within their approved dose ranges, are each producing a modest degree of cholinergic blockade in the brain, and that together are producing a degree of central acetylcholine suppression that is clinically indistinguishable from dementia on a brief office assessment. When someone asks the right question, reviews the full medication list with the right knowledge, and removes or substitutes the offending drugs, the person improves. Sometimes substantially, sometimes completely. This is the conversation I want to have today, because the difference between reversible medication-induced cognitive impairment and true dementia is one of the most important distinctions in geriatric medicine, and it is one that is missed with a frequency that should trouble everyone in the field. The medications causing it are common, widely prescribed, and in many cases not considered by the prescribing physician or the patient to be central nervous system drugs at all. Before anything else, what I share in this video is educational information only. It is not medical advice. Do not stop or change any medication without speaking directly to your prescribing doctor. Some of the medications I am going to discuss are essential for managing conditions whose risks, if untreated, exceed the cognitive side effect risks I will describe. The appropriate response to this information is a conversation with your doctor, not an independent decision to stop taking something. What I want to give you today is the specific knowledge to prompt that conversation productively. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. I have sat across from families who were planning for a parent's dementia, and whose parent improved meaningfully after a medication review. That experience is the reason I am making this video. The cognitive changes in those cases were real. The suffering was real. The grief was real. And much of it was preventable if the medication list had been reviewed with the right question. If this is your first time on this channel, subscribe right now, because every week I bring you specific, grounded information about what your body needs after 60, and this video may prompt the conversation that changes a trajectory. Let me start with the biology of how certain medications impair cognition in older adults, because understanding the mechanism is what makes the specific drug classes recognizable and the clinical picture interpretable. The brain of an adult over 60 is not the brain of an adult at 40. The number of neurons has not dramatically changed, but the efficiency of the neurotransmitter systems that allow those neurons to communicate has. Acetylcholine is the neurotransmitter most critical for memory formation, for sustained attention, for executive function, and for the rapid retrieval of information that we experience as mental sharpness. The cholinergic neurons that produce and release acetylcholine, particularly the basal forebrain cholinergic system that projects throughout the cortex and hippocampus, are among the most vulnerable to the aging process. Their baseline reserve capacity decreases with age, and they are the same neurons whose progressive dysfunction and eventual death underlies Alzheimer's disease. In a 45-year-old with a healthy, high-capacity cholinergic system, a medication that partially blocks acetylcholine receptors, an anticholinergic drug, produces a modest cognitive effect that is barely noticeable in daily function. In a 70-year-old whose cholinergic reserve has already declined significantly, and who may already have the early molecular pathology of Alzheimer's disease without any clinical symptoms yet, the same degree of anticholinergic blockade falls on a system with much less capacity to compensate. The effect is proportionally larger, the symptoms are more apparent, and they may push the person from a subthreshold cognitive state into one that is clinically recognizable as impairment. This is the mechanism of drug-induced cognitive impairment through the anticholinergic pathway, and it is relevant to a very large number of commonly used medications because the anticholinergic property is not always obvious from the medication's primary purpose. A bladder medication, an antihistamine, an antidepressant, a sleep aid, and a muscle relaxant can all be substantially anticholinergic without being recognized as such by either the prescribing physician or the patient who is taking them. The second mechanism is sedation, particularly the cumulative sedation of multiple medications with central nervous system depressant properties, each individually prescribed at a dose considered appropriate, but collectively producing a sedated state that impairs cognition, slows processing, flattens effect, and produces a clinical picture of apparent dementia in a person who is actually simply over-sedated. The third mechanism is reduced cerebral blood flow from medications that lower blood pressure more than intended, particularly in older adults whose cerebral autoregulation, the brain's ability to maintain constant blood flow across a range of systemic blood pressures, is impaired. In these adults, a blood pressure that drops into a range that would be normal or even desirable in a younger adult can produce chronic cerebral hypoperfusion, reducing the brain's energy supply and producing the foggy, slow, confused cognitive picture that accompanies it. All three mechanisms are common, all three are reversible if the causative medication is identified and addressed, and all three can be mistaken for early or progressive dementia if the medication context is not specifically examined. The first medication category I want to discuss contains the drugs with the highest anticholinergic burden in the populations most at risk. Bladder medications, specifically the antimuscarinic drugs used for overactive bladder, oxybutynin, tolterodine, sulfasenacin, darifenacin, trospium, and fesoterodine. These medications work by blocking muscarinic receptors in the bladder wall to reduce involuntary contractions. Muscarinic receptors are also the primary acetylcholine receptors in the brain, and while some of these drugs are designed to preferentially affect peripheral receptors over central ones, none of them is completely selective, and in older adults with impaired blood-brain barrier integrity, their central penetration is higher than predicted by studies in younger populations. Oxybutynin, the oldest and most commonly prescribed in this class, is among the highest anticholinergic burden medications in any pharmacological category. A systematic review published in the journal JAMA Internal Medicine found that cumulative anticholinergic drug exposure, including from bladder medications, was independently associated with increased risk of dementia diagnosis, with the highest burden medications showing the largest associations. The clinical picture produced by bladder anticholinergics in older adults is often described by families as a sudden change. The person who had been managing fine seems to have declined noticeably since a new medication was started, or the person whose cognition had been gradually declining seems to have dropped a level around the time their bladder medication dose was increased. The connection between the drug and the cognitive change is rarely made, because bladder medication is not thought of as a brain medication. For adults over 60 with overactive bladder who are experiencing cognitive symptoms, the conversation to have with the prescribing doctor is, which of my bladder medications has the lowest central anticholinergic burden, and has my cognitive status been specifically assessed in relation to when this medication was started? Newer beta-3 agonist bladder medications, such as mirabegron, work through a completely different mechanism and do not carry anticholinergic burden. They are not appropriate for everyone, but are worth discussing as an alternative in adults where cognitive effects are a concern. Type in the comments right now if you or someone you know has been taking a bladder medication, while also experiencing cognitive changes that were attributed to aging rather than specifically investigated in relation to the medication. Because the frequency of that pattern in those comments is a measure of how often this reversible cause is being missed. The second category includes the medications most people taking them would be least likely to identify as having any connection to the brain. Antihistamines, specifically the first-generation antihistamines that include diphenhydramine, chlorphenamine, promethazine, and hydroxyzine. These drugs are used for allergies, for sleep, for motion sickness, and in various combination cold and flu products. Diphenhydramine specifically is the most common sleep aid available, without prescription in most countries, sold under numerous brand names at every pharmacy. Diphenhydramine is one of the most anticholinergic substances in common use. It was developed decades before the anticholinergic cognitive effects were understood, and it remains widely used primarily because its availability preceded the regulatory frameworks that would now require more careful assessment of its central nervous system effects in older adults. In adults over 60, regular or frequent use of diphenhydramine for sleep produces a meaningful degree of cognitive impairment. The effect is dose-related and cumulative. Adults who take it several nights per week over months or years are accumulating anticholinergic exposure at a level comparable to that associated with increased dementia risk in the pharmacoepidemiology literature. And because it is available without prescription and is marketed as a harmless sleep aid, the connection between the nightly diphenhydramine and the morning cognitive fog that never fully clears is almost never made. A study published in the British Journal of Clinical Pharmacology found that self-reported use of sleep medications, including over-the-counter antihistamines, in adults over 65 was associated with significantly higher rates of cognitive decline on standardized testing over a 5-year follow-up, with the association strongest for those using medications daily or near daily. If you take an over-the-counter sleep aid regularly and you have noticed that your mornings feel cognitively slow, that your thinking is not sharp until mid-morning, or that your family has commented on changes in your mental sharpness, please mention the specific sleep aid to your doctor by its full ingredient name, not just the brand name, and ask specifically whether its anticholinergic properties may be contributing to the cognitive changes you are experiencing. And share this video right now with one person in your life over 60 who takes a sleeping tablet or antihistamine regularly, and who would not think of it as something that affects the brain. The connection they need to make is the connection this video is designed to prompt. And if you are not yet subscribed to this channel, tap that button now and ring the bell. I want to tell you about a patient I will call Dorothy, 71 years old, retired accountant from Minneapolis, Minnesota. Her daughter brought her to me with a specific concern. Over the previous 8 months, Dorothy had become noticeably more confused, was repeating herself in conversations, had missed several bill payments she would never have missed before, and had become what her daughter described as foggy in a way that felt like a different person. Dorothy had seen her GP, who had performed a cognitive screening test on which she had scored in the mildly impaired range. The working diagnosis was mild cognitive impairment, possibly early Alzheimer's disease. A referral to a memory clinic had been made. When I reviewed Dorothy's medications, I found the following: oxybutynin for overactive bladder, which she had been taking for 3 years, diphenhydramine for sleep, which she had been taking on and off but mostly on for about 2 years, amitriptyline for back pain, a low-dose prescription that had been started about a year ago, and that is one of the most anticholinergic medications in the entire pharmacological formulary, and cetirizine for seasonal allergies, a second-generation antihistamine with low central anticholinergic activity, but present alongside 3 other anticholinergic medications. 3 significantly anticholinergic medications, all started or dose increased in the preceding 3 years, coinciding precisely with the period in which her cognitive changes had developed. She worked with her GP and her prescribing urologist to substitute oxybutynin with mimicking. We substituted diphenhydramine with a melatonin-based sleep approach. We substituted amitriptyline with a non-anticholinergic analgesic approach to her back pain. At 12 weeks, Dorothy's cognitive screening score had improved significantly. Her daughter described her as back. Not entirely back to who she had been 5 years ago, but clearly and meaningfully better than she had been 3 months prior. The memory clinic appointment was canceled as no longer indicated. Dorothy told me, "I thought I was getting dementia." I told her, "You were getting oxybutynin, diphenhydramine, and amitriptyline all at once. And when we removed those inputs from your brain began to recover the function they had been suppressing." The third medication category includes a class whose cognitive effects are better known, but whose specific mechanism in older adults is frequently underestimated. Benzodiazepines and the Z drugs used for sleep: diazepam, lorazepam, alprazolam, clonazepam, zopiclone, zolpidem, and zaloplan. These medications enhance the effect of GABA, the primary inhibitory neurotransmitter in the brain, producing sedation, anxiolysis, and sleep. They are effective for acute anxiety and short-term insomnia. And in adults over 60 who have been taking them for years rather than weeks, they produce a chronic state of central nervous system suppression, whose cognitive consequences include impaired short-term memory, slowed processing speed, impaired executive function, and a withdrawal syndrome on discontinuation that itself produces significant cognitive and psychological disturbance. The half-life issue is critical for older adults. Diazepam has a half-life of 20 to 100 hours in young adults. In older adults whose liver metabolizes it more slowly, and whose fat tissue, in which diazepam distributes, represents a larger proportion of body mass, the effective half-life can extend to 150 to 200 hours. A person taking diazepam nightly is accumulating the drug to a degree that their daytime cognition is significantly impaired, even when they believe they have only taken the drug for sleep. The drug is still present at significant concentration throughout the day. A prospective study published in the British Medical Journal followed adults over 65 who initiated benzodiazepine use and found a significantly elevated risk of Alzheimer's disease diagnosis over the subsequent 15 years compared to non-users, with the risk increasing with both dose and duration. While the study cannot definitively establish causation, given the potential for confounding by indication, the biological plausibility of long-term GABA enhancement impairing the neural plasticity required for memory consolidation is strong. For adults over 60 who have been on benzodiazepines for more than 4 weeks, the relevant conversation with the prescribing physician is a carefully planned tapering schedule, not abrupt discontinuation. Abrupt discontinuation of long-term benzodiazepines produces a withdrawal syndrome that can be severe and that itself requires management. The cognitive recovery from benzodiazepine discontinuation, when achieved safely and slowly, typically occurs over months rather than weeks, as the brain's GABA receptor systems recalibrate. But in many cases it does occur, and the cognitive state that follows a completed taper is significantly better than the one maintained by chronic use. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because every week I bring you the specific clinical detail that makes these conversations with your doctor more productive and more informed. The fourth category is one that requires the most nuanced discussion, because the medications I am about to describe are prescribed for conditions that carry genuine risk if untreated, and the cognitive effects I am going to describe do not apply to everyone taking them. Certain antidepressants and antipsychotics, specifically the older tricyclic antidepressants with high anticholinergic burden, including amitriptyline, nortriptyline, doxepin, and imipramine, and the typical and certain atypical antipsychotics that are increasingly prescribed in older adults for sleep, anxiety, and behavioral symptoms, including quetiapine, olanzapine, haloperidol, and risperidone. The tricyclic antidepressants carry high anticholinergic burden through the same mechanism I described for bladder medications and antihistamines. They are effective antidepressants and effective for neuropathic pain, and for adults in whom they are the appropriate treatment for a specific indication, the balance of risks and benefits may well favor their use. What is important is that the cognitive effect of their anticholinergic burden is explicitly discussed, monitored, and factored into the clinical decision, and that the availability of lower anticholinergic alternatives for both depression and neuropathic pain, including SSRIs, SNRIs, gabapentinoids, and duloxetine, is specifically considered in adults over 60, where the cholinergic reserve concern is most significant. The antipsychotics prescribed in older adults, particularly for sleep and for the behavioral symptoms of dementia, carry cognitive effects through their dopamine blockade, their anticholinergic properties in some cases, and their sedating effects. A study published in the Journal of the American Geriatric Society found that antipsychotic use in older adults with dementia was associated with accelerated cognitive decline, higher rates of cerebrovascular events, and higher mortality, findings that contributed to black box warning requirements for the use of these medications in this population. The prescription of antipsychotics for dementia-related behaviors remains sometimes clinically necessary and appropriate when non-pharmacological approaches have failed, but it requires explicit acknowledgement that these drugs carry risks of accelerating the very cognitive decline they're being used to manage. The specific question to bring to your doctor for any of these medications is, given my age and my cognitive health, is this the lowest anticholinergic burden option available for my specific condition? And has my cognitive status been formally assessed and documented before this medication was started so that any change can be specifically attributed? Before the blood pressure section, I want to address a class of medications that generate significant patient concern about cognitive effects, and where the evidence warrants a nuanced and honest discussion rather than either dismissal or alarm. Statins, the cholesterol-lowering medications we discussed in the medications and heart video earlier on this channel, are among the most prescribed drugs in adults over 60 globally, and a subset of people taking them report cognitive symptoms, including memory impairment, brain fog, and word-finding difficulty. The FDA added a label warning about cognitive effects to statins in 2012, based on post-marketing reports of these experiences. The clinical research on statins and cognition presents a more complex picture than the individual reports suggest. Multiple large randomized controlled trials have found no significant cognitive impairment from statin use on standardized neuropsychological testing, and several observational studies have suggested a possible protective effect against dementia from long-term statin use, potentially related to their anti-inflammatory effects on cerebral vasculature. At the same time, a subset of individuals does experience subjective cognitive symptoms that resolve on statin discontinuation and return on re-challenge, a pattern that constitutes reasonable evidence of a pharmacological effect in those individuals, even if the mechanism is not established. The practical position is this: if you are on a statin and you have noticed a cognitive change that you associate temporally with starting the medication or increasing the dose, report this specifically to your prescribing physician, rather than either dismissing it or stopping the medication independently. A trial of dose reduction or switching to a different statin molecule, some of which are more lipid-soluble and more penetrant of the blood-brain barrier than others, is a reasonable clinical test of whether the statin is contributing to your specific experience. The overall benefit of statins in adults with established cardiovascular disease is substantial, and the decision to modify or stop should be made with the complete clinical picture rather than from concern alone. The fifth area concerns the less recognized cognitive effects of medications that act on blood pressure and cardiovascular function, specifically when the degree of blood pressure reduction exceeds the brain's autoregulatory capacity. We have discussed cerebral autoregulation briefly in other videos on this channel. The brain maintains a remarkably constant blood flow across a wide range of systemic blood pressures through the active constriction and dilation of cerebral arterioles. In older adults with long-standing hypertension, the autoregulatory curve shifts, meaning the brain adapts to operating at higher pressures and its lower threshold for maintaining adequate flow rises. When blood pressure medications reduce systemic pressure more than expected, for example in an adult whose medication dose was calibrated when they were less mobile and more robust, and has not been reviewed as they have become frailer, the pressure may fall below the shifted autoregulatory threshold and cerebral perfusion decreases. The result is a chronic cerebral underperfusion that produces a cognitive picture of slowing, difficulty with concentration, increased fatigue, and impaired memory that can progress over months and be mistaken for neurodegenerative change. The person is not losing neurons through a degenerative process. They are losing perfusion through an over-medicated one. This is most common with the combination of diuretics and ACE inhibitors or ARBs in older, frailer adults, and with any blood pressure medication at doses calibrated to an activity level or body weight that has since changed. If your blood pressure is being managed and you have noticed cognitive changes alongside any dizziness on standing, lightheadedness during the day, or a sense of mental cloudiness that is worse in the afternoon when blood pressure is typically lower, please bring both observations to your prescribing physician and ask for an ambulatory blood pressure assessment to determine whether your medication is producing a pressure level that is appropriate for your current age and health status. Here is the complete framework for translating what I have described into a productive medical conversation. Bring your complete medication list to your doctor, every prescription, every over-the-counter product, every supplement, including the sleep aid you have been taking for years, and consider unremarkable. Ask specifically, can you review this list for total anticholinergic burden? The Anticholinergic Cognitive Burden Scale and the Anticholinergic Risk Scale are validated tools that allow a clinician to calculate the combined anticholinergic load of a medication regimen. If your doctor uses one of these scales and finds that your total burden is in the moderate or high range, a medication review with the specific goal of reducing anticholinergic exposure is clinically warranted. Ask whether any cognitive screening was performed before any of the medications on your list were started, and whether the cognitive state you are in now has been compared to that baseline. Cognitive change that tracks the introduction or dose increase of an anticholinergic or sedating medication is reversible impairment until proven otherwise. It requires investigation of the medication context, not only investigation of the brain. Ask specifically whether a trial of gradual dose reduction or substitution of the highest burden medications is possible, with a structured reassessment of cognitive function over the following 2 to 3 months. This is not a demand to stop all medications. It is a request for an evidence-based clinical trial of a pharmacological adjustment whose potential benefit, the partial or complete recovery of cognitive function, is both meaningful and consistent with documented clinical outcomes. And if a dementia diagnosis has been made or is being considered, ask whether a pharmacological review, specifically examining the anticholinergic and sedative burden of the current medication regimen, has been part of the assessment. In many cases, it has not been, and in many cases, when it is performed, the outcome changes. 4 things to carry away. First, medication-induced cognitive impairment from anticholinergic burden, from cumulative sedation, and from cerebral hypoperfusion is common, under-recognized, and frequently mistaken for early dementia. The medications most responsible are often not considered central nervous system drugs by the people prescribing them or taking them. Bladder medications, antihistamines, sleep aids, and certain pain medications carry some of the highest anticholinergic burdens in the formulary. Second, the cognitive effects of these medications are magnified in adults over 60 because the cholinergic reserve of the aging brain is reduced, because the liver metabolism that clears these drugs is slower, and because the blood-brain barrier that would partially exclude them is less intact. The same medication at the same dose in a 40-year-old and a 70-year-old is not the same pharmacological event. Third, medication-induced cognitive impairment is potentially reversible. Not always, not completely in every case, but meaningfully and substantially reversible in many cases when the causative medications are identified and addressed through appropriate substitution or gradual reduction. The Dorothy I described did not have her dementia diagnosis reversed. She had a medication reaction identified and reversed. The distinction is everything. Fourth, the question that changes everything in this area of medicine is not which medication is the problem. It is, what is the total anticholinergic burden of this person's regimen, and what is it doing to their cognitive function? That question, asked specifically and responded to with a validated burden assessment tool, is the question that turns a dementia trajectory into a medication review. Ask it. Your brain has been doing extraordinary work across your entire life. When it changes in ways that feel wrong, the first question should not be what is broken in the brain. It should be what has been added to the medication list, at what dose, for how long, and what is the combined effect of everything currently being taken on the neurotransmitter systems that memory and cognition depend on. The answer to that question is sometimes the most important medical conversation you will ever have. Share this video with one family that has accepted a dementia diagnosis or a cognitive decline without specifically reviewing the medication list for anticholinergic burden, because the reversal that Dorothy experienced is possible for others who have not yet had the right question asked on their behalf. And subscribe to this channel, because every week I come here with one purpose: to give you the specific information that changes what you know to ask and who you ask it for. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.